ma'am, we have linked the YouTube to the live, so we can start. Yeah.
Okay.
Start.
Shall I start, ma'am?
Start.
Yes, ma'am. Good evening, everyone. On behalf of the Indian Thyroid Society, it gives me immense pleasure to welcome all of you to another edition of the ITS Thyroid Clinics webinar series. So this clinics definitely has become a platform where we discuss interesting cases, dilemmas, and again, recent advances in thyroidology. So clinicians, residents, all of them learn from the experts across the country. So we sincerely apologize for the delay in commencing the thyroid clinic session today, and we thank you for your patience and understanding as well. So before we begin today's session, let us watch a brief video of the Indian Thyroid Society highlighting our mission. So I request the tech team to display the video.
तस्य भासाय सर्वमिदं विभाति.
So before we begin, let us acknowledge the leadership and the team of the Indian Thyroid Society for supporting us through these academic ventures. So the thyroid clinics is currently being conducted under the dynamic leadership of Dr. Pramila Kalra Madam, who is the President-elect, and Dr. Roma Pradhan Madam, who is the EC member. Also, we have Dr. Narendra Kotwal sir, who is the President of ITS, Dr. Arun Menon sir, the Secretary, and Dr. Mini Ma'am, the Treasurer, always inspiring us and guiding us. We also have Dr. Chitra Ma'am, Dr. Vijay Reddy sir as part of the thyroid clinics. So moving on, a very short announcement before we proceed further. So those who are interested to submit the research to the flagship journal, that is the Thyroid Research and Practice, can do so by scanning the QR code. And those who are interested to become a reviewer for the journal can do so by scanning the QR code displayed. So moving ahead with today's program. So our session will include a case presentation presented by Dr. Sharon, Senior Resident in the Department of Endocrinology, CMC Vellore. The case discussion will be moderated by the distinguished faculty, Dr. Asha Ma'am, who is the Professor and Head at CMC Vellore, and Dr. Chanukya sir, who is the Consultant Endocrinologist at Zen Hospital, Hyderabad. So we will then have a very nice presentation, the latest ATA guidelines presented by Dr. Shashi Mauli, who is the endocrine surgeon at Sri Shankara Hospital, Bangalore, followed by quiz conducted by Dr. Suyash Gupta, consultant endocrinologist at Bhopal. So moving on, I'd like to introduce the moderators for the case discussion. So Dr. Asha Ma'am, ma'am is the professor and head in the Department of Endocrine at CMC Vellore. Ma'am has numerous publications to her credit. So yeah, and we have So ma'am is also the fellow of the Royal College of Physicians, Edinburgh. Ma'am has about 75 publications to her credit. And we have Dr. Chanukya sir, who is the consultant endocrinologist at Zen Hospitals, Hyderabad. Sir, apart from having MD and DM to his credit, also has an MBA qualification to his credit from BITS Pilani. So sir has again numerous publications to his credit. So I request the moderators to give the opening remarks and start the session. So before we proceed further, a short announcement. The quiz will be conducted slightly late today because of the delay in starting the program. So I request the audience to be with us till about 9:15, where we are going to start with the quiz. I request Dr. Asha Ma'am and Dr. Chanukya sir to start moderating the session.
Yeah, we are around only. Let us start because it is already getting too late. Whoever is presenting.
Yeah. Dr. Sharon from CMC Vellore, DM postgraduate, will be presenting an interesting case of medullary thyroid carcinoma where we have a long-term follow-up and various learnings from this case. Over to Sharon.
Good evening, ma'am. Good evening, sir. Am I audible?
Yeah, definitely. Please go ahead.
Is my screen visible, ma'am?
Yes, we can see. You can go ahead, please.
Okay. Good evening, everyone. Myself, Dr. Sharon. I'm a DM resident from Christian Medical College, Vellore. I extend my gratitude in providing me this opportunity to present today. So, I'll be presenting one of our patients who have been following up under us for more than 15 years now. So this gentleman, he's from Bangladesh. So he had initially presented in 2011 with complaints of progressive swelling in front of his neck for more than 2 years. There were no compressive symptoms. There was no history suggestive of hypo or hyperthyroidism. He had diabetes mellitus and he was a smoker. So his initial investigations and treatment were undertaken at his hometown. The ultrasound of the neck was reported as multinodular goiter. The FNAC was reported as nodular hyperplasia, and he was euthyroid. He underwent right hemithyroidectomy in July 2011, and postoperatively he had developed hoarseness of voice. And his histopathology was reported as medullary carcinoma of the thyroid. And in the postoperative, they have done a repeat ultrasound, which also showed multinodular goiter of the residual left thyroid. And then they did a calcitonin, which was found to be elevated at 727 picogram per ml. And CEA was also elevated at 132 nanogram per ml. Subsequently, he came to our center for further management. At this point, I would just like to highlight two of the biomarkers used in the management of medullary thyroid carcinoma, that is calcitonin as well as carcinoembryonic antigen. Both have a very important role in the diagnosis as well as further follow-up of MTC patients. And especially in the postoperative period, we will first analyze the calcitonin and CEA usually 30 to 90 days after the surgery when the nadir or the trajectory is supposed to set in, and they show a very good correlation with the residual lesion as well as the nodal as well as the distant metastasis. And it is the doubling time of the calcitonin as well as the CEA which is considered as an important prognostic indicator. Shorter the doubling time, more is the mortality and faster is the progression of the disease. And also, these two markers can also give us a clue regarding the dedifferentiation of the tumor. Suppose on follow-up, we see that the CEA is disproportionately elevated to the calcitonin level. That is, the calcitonin is stable or falling. This might indicate that the tumor has actually dedifferentiated now. And they can also be used in IHC staining of the histopathology specimen, even in the FNAC washout for diagnostic purposes. So our patient came to us 8 months post his hemithyroidectomy, and when on examination, he was noted to have a 4 into 3 centimeter nodule on the left side of the neck, and there were no palpable lymph nodes, and an NPL scopy showed right-sided vocal cord palsy. He was euthyroid. The calcitonin was elevated 787, and we reviewed the hemithyroidectomy slide, and it was consistent with MTC. An ultrasound of the neck was done, which showed multiple lesions in the left lobe of the thyroid with calcification. And we undertook a CT neck, thorax, and abdomen, which had only picked up the left lobe of thyroid lesions. There were no structural lesion in the rest of the neck, thorax, or abdomen to suggest metastasis. So this is a flow chart which help us understanding how to follow up a patient once the nodule FNAC of the thyroid nodule is suggestive of medullary thyroid carcinoma. So definitely we should be doing ultrasound of the neck, calcitonin and CA, and then we should do the red germline mutation. So if the red gene is found, red mutation is found positive, we'll have to evaluate for the associated conditions like pheochromocytoma. And if pheochromocytoma is found, adrenalectomy has to be done prior to the thyroidectomy. We have to look for primary hyperparathyroidism as well. If found positive,
Sharon, your voice is not audible. Sharon, you're disconnected.
Yes, it seems so. Somebody might call her. That is better.
Dr. Sharon is joining through ma'am's portal.
Can you
She's
allow me
not-
to share screen?
Yeah. Please allow Dr. Asha to share the screen, tech team.
Share screen.
Yes, ma'am.
Yeah,
Ma'am,
please
please take
just-
your, yeah.
Dr. H.S. Asha, you can allow her to share the screen, please. The
Yes,
student
ma'am.
is joining through her.
Ma'am, you can share the screen.
Can go there. Same. Next one.
Yeah, we can see the screen, yes. You can go ahead, yeah.
And this flowchart, it determines the further steps to be followed when the FNAC of the thyroid nodule is suggestive of medullary thyroid carcinoma. So along with ultrasound of the neck and measurement of the calcitonin as well as CA levels, we should do DNA analysis for the red germline mutation. And if the red mutation is found positive, we have to evaluate for the associated conditions such as pheochromocytoma. If it is positive, adrenalectomy has to be done prior to total thyroidectomy. We have to look for primary hyperparathyroidism. If it is found positive, parathyroidectomy can be done along with the total thyroidectomy. For patients who are RET negative or if it is only familial medullary thyroid carcinoma, further management can be based on the serum calcitonin levels. When the calcitonin level is more than 500 picogram per ml, which is as per the HA guidelines, suggests that it is a metastatic disease, we'll have to do evaluation for finding out the metastasis. So for CT of the neck and thorax is recommended. A contrast enhanced MRI of the liver, bone scintigraphy and axial MRI for bone metastasis are recommended. So the original HA guidelines did not suggest or recommend functional imaging. Later guidelines and studies have suggested the utility of functional imaging in picking up the metastasis. Coming to the functional imaging, F18 Dopa PET has shown to have a superior sensitivity for detecting recurrent as well as metastatic NTC. It is good in detecting occult metastases, which are not visible in the anatomical imaging. A gallium-68 DOTA PET, so it has a lower sensitivity than the F18 Dopa. It can be considered when we are planning for a PRRT therapy. And F18 FDG PET has a lower sensitivity in the initial phase, but if it is a rapidly progressive disease with a very short calcitonin doubling time, we can use this functional imaging. Newer studies have shown the fibroblast activation protein inhibitor, the FAPI-based PET, which has shown to have an increased sensitivity and accuracy. After the initial imaging and the staging, the further surgical management can be assisted by the calcitonin levels. The HA guidelines recommend the total thyroidectomy with central neck dissection as the standard of care. But if the calcitonin levels are less than 20 picogram per ml, it is recommended that total thyroidectomy is enough. When the calcitonin is between 20 to 50, total thyroidectomy and bilateral neck dissection is recommended. Once the calcitonin is more than 50 but less than 200, along with this, an ipsilateral lateral neck dissection is also recommended. And once the calcitonin is more than 200 but less than 500, bilateral lateral neck dissection is recommended. And when the calcitonin crosses 500, there is an increased risk of metastasis. So metastasis workup has to be undertaken and followed. And after the total thyroidectomy is done, based on the local disease, whether there was extensive extrathyroidal extension, extranodal extension, or there is a gross residue after surgery, it is an R1 or R2 resection, we can consider external beam radiotherapy after total thyroidectomy. So our patient underwent completion thyroidectomy plus central compartment neck dissection, and intraoperatively there was an enlarged level 3 lymph node on the right side, and that was also excised on in 2012. He did not have any postoperative hypocalcemia, and he was started on thyroxine replacement. His histopathology was noted as multifocal medullary carcinoma of the remaining left thyroid gland. There was no extrathyroidal or intravascular invasion. There was only the central compartment lymph node was suggestive of metastatic carcinoma, and the lateral compartment lymph node was only reactive hyperplasia. Hence, the staging was T1N1 MX. These images we had taken from web pathology. It just shows the histopathology of medullary thyroid carcinoma. So the tumor cells are not arranged in follicles; it's rather in nests of sheets of tumor cells. They have a densely granular chromatin. This is called salt and pepper chromatin with acidophilic granules in the cytoplasm in the perinuclear region. And we can see that in the stroma, this pink material, that is the it is the amyloid that is typical of the medullary thyroid carcinoma. And this IHC staining is positive for calcitonin.
Do you like to talk something about the postoperative complications following thyroidectomy in patients with thyroid cancer?
So, postoperatively, immediately we are expecting hypocalcemia when the parathyroid gland is inadvertently removed or devascularized. There can be recurrent laryngeal nerve palsy resulting in hoarseness of voice. And sometimes if there is extensive neck node dissection has been undertaken, laterally we can even injure the spinal accessory nerve. There can be a chyle leak also when the thoracic duct is injured. Yes. So the patient, his RET gene mutation analysis was reported as codon 634 mutation in exon 11. And this was his family screening. So this is our patient. His daughter was found to be RET mutation positive, and her son also was mutation positive. Both of whom underwent total thyroidectomy. His son was mutation negative. His paternal cousin was also found to be mutation positive and underwent thyroidectomy. So genetic testing for RET mutation is a pillar in the management of medullary thyroid carcinoma. So all the first degree relatives of patients with proven MTC and all patients who have a classical phenotype of MEN2B, such as this person with the marfanoid habitus, mucosal neuromas, patients with the cutaneous lichen amyloidosis as well, and patients with Hirschsprung's disease should be screened for RET mutation. And ATA classifies the RET mutation as highest, high, and moderate. And it is the 918T, which is the highest mutation, and 634, which is also the most common mutation of the RET gene, and A883F are the high mutation, and the rest of them are moderate risk mutations. So based on this, we can further follow up the patients as the flowchart represents. So for a child, if the child is found to be a highest risk mutation of 980, total thyroidectomy should be undertaken less than 1 year of age. And if the central lymph node is involved, then we can do a central neck node dissection. Otherwise, if the surgeon can preserve the parathyroid, central neck node dissection has to be done. For ATA high risk, total thyroidectomy has to be done at 5 years of age. And both these patients, we should follow up with physical examination as well as serum calcitonin and CA 6 monthly for the first year and followed by yearly. Pheochromocytoma screening should be started from 11 years of age. For ATA moderate risk, we can start screening at 5 years of age, and when the calcitonin level rises, total thyroidectomy can be undertaken. And similarly, we have to follow them also with physical examination and biomarker evaluation. And pheochromocytoma screening should be started from 16 years of age. For adults, we'll do a calcitonin and annual screening for calcitonin. And once it is found elevated, we'll check for the other organ involvement and subsequently thyroidectomy and further follow-up with calcitonin and CEA. The European guidelines suggest a dynamic risk stratification for post-thyroidectomy patients with MTC. So in the postoperative period, we'll assess the calcitonin and CA as well as the neck ultrasound 30 to 60 days after surgery. And the response can be divided as excellent response when the calcitonin and CA are undetectable and there is no structural evidence of the disease. Biochemical incomplete response, where the calcitonin and CA are elevated, but there is no structural disease, and structural incomplete response. So for excellent response, initially we have to do calcitonin every 6 months for the first year and then annually. Based on the calcitonin levels, we can they can be done, ultrasound neck can be done. For biochemical incomplete response, if the calcitonin is less than 150 picogram per ml, calcitonin and CA screening every 3 to 6 months is recommended to determine the doubling times. Neck ultrasound every 6 to 12 monthly, depending on the doubling time. And once if the calcitonin is more than 150 picogram per ml, then it is likely that there is metastasis. We should undertake the investigations to rule out metastasis. And for structural incomplete response, based on whether it is a stable disease or whether it is a progressive or symptomatic disease, the management varies. If it is a stable disease, active surveillance is recommended with cross-sectional imaging initially 3 monthly. For progressive or symptomatic disease, if it is a single lesion, we can go ahead with loco-regional therapy. For multiple lesions, systemic therapies with tyrosine kinase inhibitors is the method. So we followed up our patient at least for 7 years post-operatively. We see that he had an excellent response. And in 2019, he had developed an anterior wall myocardial infarction. In 2021, 9 years post-operatively, his calcitonin level became 21 and the CA was 5. In 2023, 11 years post-operatively, he had an episode of hemoptysis at hometown when a CT neck thorax was done for that, which picked up an enhancing lesion in the segment 8 of the liver. And he came to us when we found that his calcitonin had become 186 and his CA was elevated at 16. The ultrasound of the abdomen is suggestive of a solid lesion in the left 7th right lobe of the liver, suspicious of a metastasis, and a biopsy confirmed the same. BIP index was 12%. And we did a gallium-68 dotatate scan. The liver lesions were non-dota avid. There were only few subcentimetric paratracheal and subcarinal lymph nodes at that point. Then we had a tumor board meeting to decide on the further course of management for this patient, whether we had to do a surgery for the hepatic lesion, whether we had to consider systemic therapy, PRRT, microwave ablation of the liver lesion, or we have to observe. These were the considerations made at that time in 2023. So the MDT, it was decided that surgery was not feasible because there were multiple liver lesions. Same for the microwave ablation also, as there were multiple liver lesions. Because the lesion was not evident in the dotatate PET, PRRT was out of question. And because of his pre-existing cardiac morbidity, systemic therapy was also not undertaken at that time. So it was decided to keep him on follow-up and to treat if there was symptomatic progression and based on the calcitonin doubling time. He was asked to review in 4 months. However, he came back to us after 9 months when we saw that his calcitonin was alarmingly high at 1528 and the calcitonin doubling time was 5.9 months, that is less than 6 months. And CA was also elevated. So we'll just talk about the importance of calcitonin doubling time in the prognostication of NTC. When it is less than 6 months, it is said that the 5-year and the 10-year survival rates are 25% and 8% respectively. And when it is more than 2 years, it has an excellent long-term prognosis. And our patient had a less than 6 months of calcitonin doubling time. Then we did an MRI of the abdomen at this point, and there was increase in the size as well as number of the liver lesions. And he was started on tyrosine kinase inhibitor cabozantinib, 20 mg and 40 mg alternate. We reviewed him 6 months after initiation of tyrosine kinase inhibitor. And we found that the calcitonin doubling time had remained stable. CA level has slightly increased. And on structural evaluation, the MRI suggested that the liver lesions were also stable. However, by then our patient had developed intolerance to the cabozantinib in the form of diarrhea and hand-foot mouth syndrome. Hence, it was withheld. He did review with the HPV surgeons about the feasibility of the surgery, but because there were multiple lesions, it was not considered. Then after 3 months of stopping TKI, we found that the calcitonin doubling time has again reduced and his KCA was at 33. And the MRI was done at that point and it had shown a stable disease. And though he was advised to be kept on follow-up, on a close follow-up, he was lost to follow-up and then he presented again this year, 2 months back. When surprisingly, we found that his calcitonin level was 566 and his CA was 50.9. So this was a very low calcitonin level. So we thought of the differential as whether it is a high dose hook effect of the calcitonin or whether the tumor has gone for dedifferentiation. And we did a repeat imaging. The CT thorax, abdomen, and pelvis showed there was no other lesion except for the liver metastasis. And the MRI also showed that the liver lesions have increased in size. It is now nearly 8 centimeter. So after obtaining cardiac clearance, he underwent a metastectomy of the liver lesions, and he is planned to be initiated on redirected tyrosine kinase inhibitor, that is selpercatinib. So, as per the ATA guidelines, the recommendation for the management of the liver metastasis is surgical resection for patients who have large isolated hepatic metastasis, and chemoembolization can be considered when the patients have disseminated tumors, but they should be less than 3 centimeter in size and involving less than 1/3 of the liver. This was the specimen of our patient. He had underwent metastectomy on 2nd of June 2026. The HPA report is awaited. The systemic therapy that we can consider in the metastatic MTC patients include the RET inhibitors, both the multikinase inhibitors and the specific inhibitors, systemic chemotherapy, and the PRRT therapy. The multikinase inhibitors that are approved for the management of MTC are vandetanib as well as cabozantinib. And there is a progression-free survival of 30 months with vandetanib shown by the Zeta trial and 11 months shown by the EXAM trial for cabozantinib. And the common adverse effects include diarrhea, hypertension, fatigue, and for cabozantinib, palmoplantar erythrodysesthesia are found. The selective RIT inhibitors, which have a better tolerability and side effect profile compared to the multikinase inhibitors, and they are also effective in mutations that can cause resistance to the initial MKIs. This is selpercatinib and pralsetinib. Coming to the conventional cytotoxic chemotherapy, any combination of single agent or combination chemotherapy, there is hardly more than 20% response for treatment. So in comparing all these three regimens, it is a selective RET kinase inhibitors that have shown the maximum overall response rate and the more prolonged median progression-free survival compared to the other two. Then PRRT, that's peptide receptor radionuclide therapy, is one of the newer agents we have in the armamentarium against the metastatic MTC. Because the MTC cells express the SSTR2 receptor, this can be used as therapeutic agent. The radiopharmaceutical used are the lutetium-177.88, yttrium.88, and the indium-labeled peptides. Various studies have showed objective response of at least 10%. To summarize, the medullary thyroid carcinoma in adults often presents with metastasis, and the preoperative diagnosis can be quite challenging, especially in non-familial cases. And the degree of calcitonin and CA elevation and their doubling times can be used as a powerful marker for their follow-up. And long-term follow-up is the key in the management of MTC, and ideally, the management option should be discussed in MDTs. And novel systemic therapies, including the newer tyrosine kinase inhibitors and PRRT, have demonstrated improved survival. Thank you.
Dr. Chanakya, any comments, suggestions?
Yeah,
Anything you need to
there
add?
are few things which as endocrinologist, I'm hearing this one echo only. It's okay. What assay specifically you use it for this estimating these tumor markers?
So here we use
Sorry,
Chemiluminescent immunoassays.
same platform you follow.
Yes.
Okay. So in a setting, because as endocrinologist we had to know about these assays. Can you mention few pitfalls with these assays other than what you have mentioned? Hook effect. Other than
there can heterophile antibody can cause a pseudo elevation of the can be there.
fine. Second one is most common, where patient may not tell the drug history. Which drugs can lead to false positive elevation of calcitonin? Common drugs. proton pump inhibitors that already might have read. Okay. And if the patient has got renal insufficiency, especially if GFR is failing less than 45, there is accumulation of this calcitonin because it is primarily cleared by kidneys, isn't it?
Yes.
So in such settings also you have to be careful. And last but not least is whenever patient is in ICU admitted with other morbidities, the test what we do, our
Procalcitonin.
procalcitonin, that interference also will be there. So all these things we have to keep in mind as an endocrinologist. Because all these multi-kinase inhibitor or specific inhibitors, they will be taken care of in medical oncology. But in our domain, what we have to see, so that because we are the beam for these things, for other departments. So can you tell briefly about other confounders for CAS also?
So CA can be seen in other malignancies also and in non-malignant conditions as well. Again, in smokers and in other benign conditions like IBD, hepatitis, CLD, and metastasis, hepatic metastasis from any other lesions, benign breast diseases. In many conditions, we can find elevation of CA. It is not a very specific marker for medullary thyroid carcinoma.
We have to be a bit careful because the baseline CA almost doubles.
Yes.
In normal CA, if we look as a non-smoker around 3, something like that, nanogram per ml. But even up to 10 also in chronic smokers who may not have COPD, chest is normal. So we have to take with a pinch of salt. So other things you have mentioned. Okay, you are running a lab where you have got these false. I'm dealing only with endocrinology, isn't it? I'm not going to discuss these things. So high dose effective, by doing dilutions. But for these heterophile antibodies, what are those measures you are going to take if you are going to establish a laboratory in your hospital? In future, not now. When you see the similar patient in your hospital, when you are alone practicing endocrinologist, when you suspect these things, you have done in dilutions, everything is fine. There is no high dose hook effect. Still, it is showing just like last value. You have shown one thing, lower, unsuspecting lower value of calcitonin. So, what are those measures you are going to take in your lab?
We can subject the testing. The testing can be done in another platform, more credible platform that can be done, sir.
Actually, there is one more also.
We can run in.
Exactly. Here, usually in dilution, when you are doing 1 in 10 or 1 in 100, usually there will be serial dilutions. But even for these interfering antibodies also, if it is not serial, means sometimes showing a spike value, sometimes showing lower values, then you have to suspect these things. Otherwise, what you have mentioned, that means platform switching. Good. It's okay. Dr. Asha, it is left for you. Thank you.
Thank you, Dr. Chanakya, for highlighting some of those very important aspects of the assays, which we quite often don't pay much attention to. And in this case also, though the tumor was growing in size, the calcitonin coming down, and only a mild increase in the CEA. We did not do it in dilution at that time, but looking back at it, we should have done calcitonin in dilution at that time, or it could be a dedifferentiation of the tumor also. Very important points have been highlighted regarding the assay. The learning points for us here were mainly the long-term follow-up, what can happen in a metastatic MTC in the course of the illness, as the metastasis evolve. How do we manage metastatic disease? How do we look at the whole body imaging, especially the different PET scans, and take it up. PRRT would have been an option provided that the lesions were avid on the gallium dotatate scan. But unfortunately, the liver lesions here were not DOTA-avid, and hence that could not be considered. Over to you, Dr. Gan.
Oh, sorry. Yes. No, somebody can ask us. Later I will ask.
Yeah, ma'am, if I may add.
Yes, please.
Just one more point. So in medullary thyroid carcinoma, when the patients have this secretory diarrhea and stuff, so what happens is there is a role of even debulking. So if the surgeon can debulk the 90% of tumor because these are neuroendocrine tumors. So still the quality of life would be better for them.
That is the problem, sir. Actually,
So
we
that
don't
is
estimate
one
VAP
point.
in those levels. Sometimes that is a paraneoplastic syndrome, sir, because of MTC. What you just mentioned about diarrhea, if we can measure prostaglandins, okay, or VAP kind of those things, so definitely we can further pinpoint the diagnosis. Only thing is that collaboration between our endocrine surgeons, our endocrinologists, because so many are involved here, medical oncologists, and our nuclear medicine specialist. Here, the linchpin is with the endocrinologist because he or she has to coordinate entire these things. Thank you.
Definitely, diarrhea is a significant problem in a good proportion of metastatic MTCs, and in such situations, the commonly also helps. And as Dr. Shi pointed out, any resectable metastasis reduces the tumor burden and the calcitonin levels and the other tumor markers, and hence would also help in remission of the controlling of the diarrhea.
Voice is a little bit breaking. I want to ask just one question. Actually, that is one of the interesting questions which was when I was resident at this one. Our assistant professor used to ask. So, what is that relation of, because now the case is typical, isn't it? That is meant to A, and cutaneous lichen amyloidosis. Can you tell link between these two?
Sir, cutaneous
This-
lichen amyloidosis, it can even be considered as it can predate the onset of MTC. Patients can have this intense itching, which improves on exposure to the heat, and it worsens on stress, and later the hyperpigmentation can develop. So this can even be considered as a precancerous lesion. So in that stage, if we do a RET mutation analysis for patients with the CLA, and we get the RET mutation positive, then we can do a todothyroidectomy prophylactically. The MTC can even develop after a CLA.
It is specific for the codon 634 mutations.
Exactly. Why it specifically happens in that interscapular region? Classical distribution we have been reading for almost, now I am reading for 25 years, same thing over and over and again. Any forethought about that thing? Why not in other areas? That is homework for you. Actually, recently only I came to know about that thing. It is not to test your knowledge, because after 25 years only I realized this one, why it is happening in that specific region. So if it is possible, you can use me with that also. Thank you.
May I have a question, please? What is the role of liver transplantation in such patients when the liver lesions were discovered initially?
Sir, here it is not more than 50 to 60% of the liver. When more than 50-60% of the liver is involved, then there is a role to consider liver transplantation, provided there is no metastatic disease elsewhere in the body. With this level of calcitonin, though we don't find metastatic disease elsewhere, we can't be 100% sure. So I think the role of liver transplantation in such a situation would be less, is what I consider.
Thank you.
Over to you, Dr. Kanu.
Thank you, Dr. Sharon. Definitely a very, very interesting case presentation and a very clinically challenging case as well. So I thank the moderators, Dr. Asha Madam, for setting the context and for an excellent moderation, and Dr. Chanukya sir for leading an excellent discussion as well. So we will move on to
discussion. That I'm learning from you all. It is always two-way process. Learning is always two-way street.
Yes, sir.
Thank you.
Thank you, sir. So we will now have a presentation by Dr. Shashi Mauli sir, who is a consultant endocrine surgeon at Sri Shankara Hospital, Bengaluru, who will be speaking on the latest ATA guidelines. So over to Dr. Shashi Mauli sir for your presentation.
Yeah, is my screen visible and am I audible?
So you can put it on full screen mode.
Yeah, yes. Okay, so without further ado, I'll just go with this. I thank ITS for giving me this opportunity. And yeah, the disclosures are that 88, 2015 and 2025 guidelines have been used with some AI generated images. I'll try to demystify this version, and 20 minutes is definitely not so sufficient for this. So I'll be going fast with a few slides, and few slides I'll halt and explain. So there is more refined risk stratification in this 2025 with de-escalation strategies and expanded molecular testing with patient-centric outcomes. Main important thing is the data approach, which we'll see further, and the surgical management and the other things which like radioactive iodine, TSH suppression has been de-escalated. The risk stratification has gone from 3-tier to 4-tier, which is more specific. And the response criteria also covers more of lobectomy. And then, of course, the surveillance, cancer survivorship, and the advanced DTC has been covered in a good amount of detail in this 2025. Now, they have one strength of recommendation that is conditional, which was not there previously. And also, good practice statement is what they have included. So now comes this data framework, which is the base of this 2025. It's diagnosis, assessment, treatment, and then assessment, active surveillance, and then again reassessment, and which has been there for both the therapy, dynamic risk stratification, persistent or recurrent diseases with, and also for radioiodine refractory diseases and those who fail on second line. I'll not go much into detail with the epidemiology, and just that the incidence has been tripled, and the role of FNAC for small thyroid nodules have been reduced. It remains the most, the DTC has got the best survival rates. And in this, the oncocytic thyroid carcinoma has been separated out, and then they have given a separate risk stratification for oncocytic thyroid carcinoma as well. So coming to the pathology, this is NIFTP and the difference between the NIFTP and follicular thyroid carcinoma. If you have the nuclear cytology features present, then it goes to the one side of FEPTC. Previously, it was encapsulated variant of FEPTC, now which has been renamed as NIFTP. If there is invasive, then it is called as invasive FEPTC. And if there is no nuclear features, then it becomes either follicular adenoma or follicular thyroid carcinoma. So with this base, we go to the low risk neoplasms. So they are basically NAFTP, uncertain malignant potential tumors, and hyalinizing trabecular tumor. As we see that the rest of the malignant neoplasm, PTC, FTC, IFPTC are there, and then the oncocytic carcinoma has been separated out. Now we also see that there are some high grade follicular derived non-anaplastic lesions. So these are poorly differentiated, and it was already there. There is a set criteria for PDTC, and now the WHO 2022 has introduced differentiated high-grade thyroid carcinomas, which have the differentiation of high-grade, the normal thyroid carcinoma, but with high-grade with more mitotic count and tumor necrosis. Now coming to starting with the 2025 guidelines, NAFTP is the first recommendation, where this was not included in 2015 because it was introduced, the nomenclature was introduced somewhere in 2016 by Nikiforov. So for this is a diagnosis on a nodule which has been removed, not a FNAC specimen, and it's a very low malignant potential tumor where the surgery is only hemithyroidectomy or lobectomy. And then there is no further requirement for completion thyroidectomy if the opposite side is normal. And this is the criteria for the pathological diagnosis of an FTP. Now coming to recommendations 2 to 5, they are all genomic ones, which I have not included in this. The recommendation 6 on the left side, we see 2015, which says that the high volume is around more than 100 cases, but now it is more refined that 25 to 30, 25 to 50 thyroidectomies per year is considered as a high volume. And we see that I'll show it in the next graph. that you see one case per year has got a complication rate of 87% of odds, whereas which reduces to 3% in 25 to 50. Now, coming to evaluation and imaging, there's not much of difference on ultrasound, except for that FNA TG with the lymph node has been just made a conditional recommendation. And cross-sectional imaging also, there's not much of a difference, only that we have to know that the IV contrast can be given for these patients if required. And this has become now a moderate certainty evidence. Now, initial management, there are two things. One is non-surgical for T1A lesions, that is less than 1 centimeters, and that is by either active surveillance or percutaneous ablation, which I'll show it in the next slide. And in case of active surveillance, it is the ultrasound which is to be done, and no need for TSH suppression and measurement of TG or anti-TG antibodies. And on subsequent ultrasounds, if there is more than 3 millimeter or is other high risk features, then the patient should go for surgical intervention. So this is the active surveillance which we see. It's for less than 1 centimeter, no high risk features, no TSS suppression, no TG requirements. Follow up is 6 monthly for 1 to 2 years, then annually. The only problem is that we don't know the length which is necessary for follow up, and none of the studies have included the CT scan of for routine measurement. And next comes the ablation. Radio frequency, microwave, and laser ablation have been seen. The indications are same. These three modalities have got various response rates. Though the tumor disappearance rate somewhere between 57 to 91%, and the pole recurrence rates is 0.4, which is pretty less, and complications are around 3.2%. So the RFA has got a good volume reduction, 99, with microwave has got 95, and laser ablation 89%. Now, if we see this, this is the 2015 and 2025 guidelines regarding the surgery. So we see that it's 1 to 4 centimeter, less than 1 centimeter was also active surveillance was prescribed in 2015 with in certain cases. Now it has come up with full evidence. From 1 to 4 centimeters was the one which was in this area of lobectomy. Now it has become 2 to 4 centimeters, that is T2 lesions. And the next one is, so the next one is that, as I said, less than 1 centimeters, it was only lobectomy. Now it is 100%. Less than 2 centimeters is lobectomy without any nodal metastasis. Sorry. Yeah, and there is no difference for the rest of the tumors. Now, this is the treatment summary where you see that you can see that T1 and T2 lobectomy, and T2 lesions total thyroidectomy in certain cases, whereas anything more than that is always total thyroidectomy with or without neck dissection, depending on the nodal burden. Now, completion thyroidectomy, it remains the same. There's no differences per se, but yeah, there is a you can consider completion thyroidectomy for oncocytic thyroid carcinoma because of they are a little more aggressive, and also the radioiodine therapy may not be much useful in them. Coming to thyroglossal duct carcinoma, more or less remains the same. If the thyroid is normal and the thyroglossal duct has a carcinoma, cystron is the standard of care. And if there is any suspicious thyroid nodularity or there is a significantly enlarged thyroid nodules, then cystron with total thyroidectomy. And in case of any neck nodes, then further neck dissection. Now, prophylactic CCLND and other lymph node dissections also don't vary much, except for the central compartment now includes the level 7, and lateral compartment specified that it is from level 2A, 3, 4, and 5B. And if there is any lymph nodes beyond this inward, then it has to be included. Now, there are two things which have been included in this particular guideline, that is lymph node yield and lymph node ratio, which is a very good thing, that the lymph node yield to rule out metastasis with 90% of confidence. For T1B lesions, at least 6 lymph nodes have to be there. For T2 lesions, 9, and T3, 18 lymph nodes have to be there. So it is difficult to say that no, we can include or not. But if as the size increases, the lymph node involvement also goes, and also that the surgeon has to be very judicious in doing the lymph node dissection. Now, prophylactic central compartment lymph node dissection, one of the study where they found that the recurrence has happened in 20 out of 125 patients, where the recurrence was more in those had less lymph node yield, that is 2.5 versus 10.3. Similarly, in the lateral neck dissection also, the lymph node yield was less. Now coming to lymph node ratio, that is the number of positive lymph nodes to the number of lymph nodes dissected. So the lymph node ratio more than 0.19 shows reduced survival, 10-year survival. And also if the lymph node ratios with 18 positive lymph nodes and more than 0.19 is a very high significance for adverse outcomes. Also, as the ratio increases, then the local regional recurrence chances will be more. Voice nerves and parathyroid, I'm not going into detail. I think Roma ma'am has discussed these in detail. So they have to be saved at any cost. And neuromonitoring, if available, is very good to use. And the parathyroid glands, yes, we have to supply, we have to save them with the blood supply properly. If devascularized, auto transplantation is must, and vitamin D deficiency has to be corrected before. Now, postoperative drainage, coming to this, they recommend not to put any drains, but this is a conditional recommendation. Though in India, we still use drains because of various reasons, large thyroid, surgeon comfort, and some lymph node dissection, definitely a surgeon is going to use. This is the TNM classification, AJCC 8. So now less than 55 years, it is only stage 1 and stage 2. Previously, it was 45 years. So these are the major changes in from the 7th edition. So age is changed from 45 to 55, and minimal extrathyroidal extension has been T3, and T3A is just only 4 centimeters. T3B has got a new category which has got gross extrathyroidal extension. Now, this is the most important thing, the risk stratification. So this was the 2015 where there was a 3-tier risk stratification, low risk, intermediate, and high risk. And we have got a lot of information in this, but still there was a lot of there were a lot of nuances which had to be dealt. So there comes the 4-tier risk stratification, and this has to be done after the surgery along with the histopathology and TG and anti-TG antibodies, and then in conjunction with the 8th edition of AJCC. So molecular profiling is not routinely recommended at this particular point of time until unless it's a metastatic or radioiodine refractory. So these are the parameters which I will go in brief, based on which the risk stratification has been done. The unifocal, multifocal, for T1A, the risk of recurrences are there. So once it becomes multifocal, it increases, and compared to unilateral versus bilateral, again, it is almost doubled. The PTCs and FTCs without and with vascular invasion, the vascular invasion in PTC, it's almost 21% of recurrence risk. FTC less than 4 vessel and more than 4 vessels, you can see the stark difference. And also the lymph nodes, as the lymph node size increases, as well as there is extranodal extension, it goes as high as 40 to 50%. Similar with extrathyroidal extension, this without lymph node involvement with PT3A versus 3B, it's 3 to 9% versus 23 to 40%. And margins positive, anterior margins positive, the risk of recurrence is less, whereas the posterior margins are positive, then the risk of recurrence is high. Now, this is what the 4-tier this thing is. I couldn't fit it in single frame, so I had to divide it into 2. There is a low risk where the risk of recurrence is less than 10%, and T1 to T2, this is unifocal, N0 or N1 with low lymph node burden has been involved in PTCs. We see that FEPTC, IFEPTC, and OTCs have been separated out, and they also have the similar stratification where it is T1 and T2, node negative or low lymph node burden, minimal invasive capsular invasion without any vascular invasion. Then comes low to intermediate, where the risk of recurrence is around 10 to whereas bilateral multifocality comes in the next slide. And nodal disease, yes, more than 2 millimeters, that is more than micrometastasis, or more than 5 lymph nodes. And if there is negative margins or even posterior margin, yes, it is included in this. Now, coming to FEPTC and IV-FEPTC, there is limited vascular invasion, less than 4 vessels, which has been included apart from this. Now, coming to intermediate to high risk, the risk of recurrence is 16 to 30%, where this includes bilateral multifocality, more than 1 centimeter, and there is clinically evident lateral lymph nodes, which has been included in this rather than the previous ones, and that is less than 3 centimeters. And anything apart from the 2+ low intermediate risk factors are also in this. Similarly, intermediate to high with FEPTC and OTC, clinically evident lateral lymph nodes, which is less, of course, in FTC and OTCs. Whereas the high risk has got all the high risk features, T3A plus extrathyroidal extension, lymph nodes more than 3 centimeter, PDTC is high grade, extranodal extension. And in this, we have got more than 4 vessel involvement for FTCs and OTCs. So this is a very detailed risk stratification, which is useful for all the physicians, surgeons, nuclear medicine physicians. And yeah, this is the genomic testing, which has been mentioned, but it is not done at this particular point of time. But yes, we do see RAS, PPR, gamma, which are of low risk in FTCs and NIFTP OTCs. And papillary thyroid carcinoma, BRAF with other red NTRK, ALK, these are intermediate. I'll tell this in the later stage. And then when they become, when there is associated TERT, TP53, PIK3CA and AKT1, they become high risk. So these risks are basically used if at all the FNAC was not, when we do on an FNAC, some people do it and they get it done, all the mutations done even on FNAC even before doing the surgery. So that can guide the surgery, but this is not indicated according to the ATA or AJCC. So now coming to this somatic genome testing, you see that if it's only BRAF, it's moderate risk, whereas when it combines with TERT, even RAS or BRAF with TERT, it becomes a high grade. Now clinical response, this previously was measured at 2 years in 2015, now it is at 3 months, and at any point of time we can measure on follow-up. During the follow-up, it is mentioned in 2025. Now it is divided into 4 categories, that is excellent response, indeterminate, biochemical, and structural. Now excellent response, even in this they have divided in 3 categories, that is, one is post-total thyroidectomy without neck dissection, and with RAI ablation, without RAI ablation, and also for post-hemithyroidectomy, which was not there in 2015. Now, these are the values for excellent, indeterminate, biochemical, and structural, not going into detail. But for this category without RAI ablation, non-stimulated levels are 0.5 to 5 in indeterminate, more than 5 in biochemically incomplete. Whereas post-thyroidectomy, there is no role of measuring any thyroglobulin level, though we do, some surgeons and some physicians do. And this is the most important one, the TSH suppression, which was there as a 3-tier classification in the 2015, has been removed, and it's only 2. The excellent and indeterminate response does not require much of a suppression, and it has to be in the normal range, whereas for biochemical incomplete and structurally incomplete or recurrence will have to be suppressed less than normal range, that's all. Follow-up is with ultrasound and radioiodine whole body scan, 6 to 12 months follow-up in the initial, and thereafter, depending on the risk, If there are any suspicious lymph nodes, yes, you go ahead with FNAC and treatment accordingly. The most important thing on RAI is these patients, those patients who have not without RAI don't need any surveillance whole body scan. So now coming to the response data after the initial therapy, again the same thing. This is the you assess it after 6 to 12 weeks, and then you take a decision whether RAI is required or not, and then reassess after a certain point of time. Now, remnant ablation after total thyroidectomy, which was in 2015, now there is no recommendation for um, remnant ablation in a low risk category. Low to intermediate, you can consider, you can even skip in certain cases, but for high risk and metastatic, it is a must. Now, this is what was mentioned in the previous slide. So that is we can see the dosage which can be given in each category, and this intermediate to low and intermediate to high, we can consider giving a radioiodine ablation depending on case to case basis. Now the recommendations 33 to 37, there's not much of a difference except for one important thing, that recombinant TSH has been preferred over the thyroid hormone withdrawal in this particular 2025 guidelines. And the thyroid hormone withdrawal has to be 3 to 4 weeks, and if it is more than that, you give supplementation with LT3. And rest of the things are more or less same. And also RSTSH can be used in metastatic, which was not previously, which was in a gray zone according to the previous guidelines. And these are the next recommendations are regarding RA ablation. There is not much of a difference in this. Now, long term, once we know that when there is an excellent response, we don't intervene, get the diagnosis, surgically amenable or local therapy or RAA, whichever is possible, then do the assessment again and then monitor these patients. So once this is what is the TSS suppression, as I said, low risk and low to intermediate doesn't require any suppression, and only for the metastatic they require lower than normal value. Now, what is the role of TG in follow-up? So there is a very definite role after total thyroidectomy, but not in the hemithyroidectomy patients, and that is what has been mentioned here in this recommendation, and rest of things are the same as that of the previous one. Now, coming to low risk DTC with excellent response, we can see that in hemithyroidectomy, as I said, you just some people do once post-operatively, some people do not do anything, and the most important thing is the frequency of neck ultrasound once after 1 year, and then every 1 to 3 years for the next 5 to 8 years, and then depending on the TG levels, TG anti-TG antibody levels. Now, this is the the data for dynamic risk stratification. We see that there is an excellent response. Then you again categorize depending on the previous one, low, low, intermediate to high, and then you assess the risk of recurrence in each. And then according to the indeterminate, then it comes to 5 to 20. As it increases, then the risk of recurrence is higher. Now, going further, if there is a recurrence, surgically amenable disease has to be done with dealt with surgery. The other options are ablation techniques, and RA only for isolated lymph node mets is not recommended until unless you do a compartment dissection, or if there is unresectable, then you can consider EBRT, that is in the form of IMRT or SBRT, and then go ahead with RA therapy. Now, coming to the radioiodine refractory disease, how is it classified? They have given a very good definition that patient at least must have been done, and it has to be negative after the whole body iodine whole body scan has to be negative after at least one ablative dose. Otherwise, they do not. We do not categorize them as a radioiodine refractory. Now, these patients with radioiodine refractory, when do we give them any therapy? If they are asymptomatic, minimally progressive, do not have any issues, we just put them on suppressive dose and then follow up them with imaging. Only if they are symptomatic and there is the growth is at a faster pace, then you try to go ahead with therapy. What are all the therapies available? We get a biopsy when we have to go ahead with therapy. We better get a biopsy and do a next generation sequencing, and then if there are any actionable mutations, treat accordingly. Otherwise, it is usually lenvatinib or sorafenib. And the second line drugs for this, if they progress on lenvatinib or sorafenib, is cabozantinib. Some role of PD-L1 immune check inhibitors like pembrolizumab, but response rates are not so good. It's just in a single digit. Then if there is any progression, we go to second line therapy. Now, this is very important as compared to the anaplastic thyroid cancers, where in differentiated thyroid cancers, we have this particular recommendation that even if there is an actionable mutation of BRAF, we usually start these patients on lenvatinib, and if they progress, then only we go ahead with dabrafenib trametinib. This has been also reinforced by the ASCO guidelines, which has been recently released in April 2026. Now, this is the framework for radioiodine refractory disease. You have a guided mutation, then you go ahead with it. Otherwise, go ahead with lenvatinib. Now, once there is a recurrence or there is a progression on first line therapy, then you have the other set of therapies like anti-RK inhibitors, red fusion cell percatinib, pralsetinib, birafis, dabrafenib, and trametinib, and other ALK inhibitors. So the same thing has been given in this. This is for those who progress on first line, and then the second line treatment is this. Now, coming to redifferentiation therapy, it is not given in those who are radioiodine avid, but they are in radioiodine refractory. Now, selumetinib is one of the agents which has been used, and the others like cytotoxic, the other recommendations for cytotoxic chemotherapy is very less. Oligometastatic is 2 to 5 meds, and you site-specific metastasis can be treated with either surgically amenable, then do surgery, or else with ablative techniques. Bone-directed agents have been indicated in certain patients. Yes, bisphosphonates or denosumab can be tried, but it is not
Dr.
outrightly.
Sasi, sorry to interrupt, but if we can wind up fast because the quiz
Yes,
also is there.
Yes.
Yeah. Sorry. It's very
No.
nice, but
Yeah,
we
so
have
I'm
the
not
time
going much in
limitation.
genetic details. So the familial syndromes associated with differentiated thyroid cancers are this. So summarizing the guidelines, we have a data framework, then work up with cervical ultrasound and cross-sectional imaging. FDG PET is not routinely done. Then for smaller lesions, PT1A, active surveillance or ablation. Then this is the preferred treatment for lobectomy is preferred for T1A, T1B, and T2. And then we have the risk stratification, assessment response. Then we have this molecular testing. This is one important slide where you don't do routine pre-op molecular testing for all the DTCs, only in radioiodine refractory. So this is the survivorship arc, and they have included survivor, financial toxicity, and other things. So take-home message for 2025 is basically precision is personal, and we treat the tumor, the biology of the tumor, less for less aggressive, more for more aggressive. Thank you.
Thank you, sir, for a very clear presentation and a very extensively also you have presented regarding the guidelines. One of the very hot topics in the field of thyroidology at present. So moving on, and now one of the most awaited segments, though we are running late, I request everyone to participate, the ITS Thyroid Clinics quiz. I request Dr. Reddy, sir, to introduce the quizmaster, Dr. Suyash Gupta.
Thank you, Dr. Gannavi. It's an honor for me to introduce Dr. Suyash Gupta, the quizmaster for today. He's consultant endocrinologist, Krishna Diabetes, Obesity, Thyroid and Hormone Clinic, Bhopal. And he has done DM endocrinology from MS Ramaya Medical College, Bangalore. He's got multiple awards in RSSDA and Diabetic Food Society, and he's published many case reports. Over to Dr. Suyash.
Sir, we'll go through the quiz rules, sir, and
Yes,
I will
sure.
give you the cue, sir. Yeah, when to start. Let people join.
Dr. Suyash, let's give some
Yeah.
time. We'll go through the quiz rules first.
Sure. Thanks a lot for the introduction, sir. And I'm very privileged, and it's an honor me to join as a faculty link with the faculty link where my mentors are here. Whenever I get the clue from the tech team, we'll go for it.
Sure. So just going through the quiz rules. So to participate in the quiz, click on the button, attend quiz button given on the screen, which is being live streamed. Quiz will be conducted through a platform called Slido. You are requested to use a laptop for ease of experience. Quiz will run for 5 minutes. The quiz master will display case or description of question by screen sharing a PowerPoint file. There will be 10 questions. Each question will be available only once for 30 seconds with the timer on. Kindly do not refresh the page or go back onto the page. Just give few minutes for.
Yeah, we'll wait for a few minutes, sir. 2 minutes, and
Yes.
then we'll start. So, yes, sir, you can screen share, but not the questions, the first page. Yeah.
Yeah, I think I've already done it. Is it okay?
Yeah. Just go to the slide mode, please.
Yeah.
Please click on the slideshow. Yeah. Done. So we can start with the first question, please.
Yes, sure. So here's presenting the first question. I hope everyone's ready. Which mechanism primarily explains the myogenic delay in the relaxation phase of deep tendon reflexes in hypothyroid patients? Is it A, decreased calcium ATPase activity, B, mucopolysaccharide infiltration in muscle, C, selective atrophy of type 1, that is slow twitch muscle fibers, or D, that is slowing of peripheral nerve conduction velocity?
Sir, you'll wait for my cue to next question, sir. I'll give you the cue.
Sure.
Yeah. So next question, sir.
If a patient on 100 microgram of LT4 is switched to combination therapy, what would be the approximate revised LT4 dose if 5 microgram of LT3 is added? Is it A, 75 microgram, B, 85 microgram, C, 95 microgram, or D, 100 microgram?
So next question, sir.
What is the primary mechanism by which metformin therapy can lead to a suppression of serum TSH levels in diabetic patients? A. Direct stimulation of pituitary thyrotrophs. B. Upregulation of thyroid hormone receptors. C. Inhibition of hypothalamic AMP kinase enzyme. Or D. Increased peripheral conversion of T4 to T3.
So next question, sir.
Which preoperative serum calcitonin level is considered as the cutoff for defining low risk MTC? Is it A, less than 20 picogram per ml, B, less than 100, C, less than 250, or D, less than 500?
So next question, sir.
In patients with a sustained excellent response after total thyroidectomy for low risk DTC, when can routine ultrasound monitoring be discontinued? A, 1 to 2 years post surgery. B, 5 to 8 years post therapy. C, only if thyroglobin becomes detectable. Or D, never.
So next question, sir.
Ectopic thyroid glands, such as a lingual thyroid, often fail to maintain euthyroidism during adolescence because A, the ectopic environment inhibits deiodinase type 2 activity. B, they are more susceptible to destructive subacute thyroiditis. C, they lack lateral lobes and have restricted proliferative capacity in response to TSH. Or D, pubertal androgens act as competitive inhibitors at the ectopic TSH receptor.
So next question, sir.
What is the most common type of thyroid carcinoma arising within a thyroglosal duct carcinoma? Is it A, papillary carcinoma, B, follicular carcinoma, C, squamous cell carcinoma, or D, anaplastic carcinoma?
So next question, sir.
For a patient with a unilateral low-risk differentiated thyroid cancer, what is the preferred initial surgical approach according to the 2025 ATA guidelines? A. Thyroid lobectomy. B. Total thyroidectomy. C. Total thyroidectomy with prophylactic central compartment lymph node dissection. Or D. Subtotal thyroidectomy.
So next question, sir.
According to the fifth edition of the WHO classification, which histomorphologic features are required to classify a lesion as differentiated high-grade thyroid carcinoma? A. Solid trabecular or insular growth patterns with a mitotic index of more than 3 per 10 HPFs. B. A mitotic count of more than 5 per 2 millimeters square and or the presence of tumor necrosis. C. The presence of convoluted tumor nuclei and a lack of papillary nuclear features. Or D. A Ki67 proliferation index exceeding 20% in at least 3 distinct tumor regions.
So next question, sir.
In the management of thyroid eye disease, how does the clinical activity score guide treatment differently than the severity score? High severity score requires pulse steroids regardless of the CAS, the clinical activity score. This is the option A. B option, high CAS requires immunosuppression, while high SS without active inflammation may require surgery. C. CAS measures proptosis and diplopia, while SS measures eyelid redness. Or D. Immunosuppression is only indicated if both CAS and SS are low.
So we are done, sir.
Thank you.
So Yash, you can discuss the answers. Meanwhile, the tech team can get the results of the quiz ready.
Sure, sir. So I've shared on my screen the answers for the quiz we have just had. I'll quickly go through all the answers. So question 1, the answer was decreased calcium ATPase activity, being the mechanism which primarily explains the myogenic delay in the relaxation phase. So there's this flagship journal by the Indian Thyroid Society, Thyroid Research and Practice, which shows about, you can go through it to quickly get a hold of all these important concepts. So it also mentions that calcium ATPase activity of a fast twitch variety of muscle fiber is decreased in hypothyroidism, causing the delayed relaxation, the hunger reflex. Question 2 was about the dose of LT4, LT3 adjustment. The answer is 85 microgram. How did we get it? Again, in the flagship journal of Indian Thyroid Society, they have specifically mentioned the same example as I have mentioned, that LT3 dose can be like reducing the LT3 dose by 3 times the LT4 dose. In the similar example as I quoted, if the baseline LT4 dose was 100, the LT3 dose is calculated to be approximately 1/17th of the current LT4 dose, which is around 5. So the revised LT4 dose would be therefore be 85 because we reduced it by 3 times the LT3 dose. Next question was about primary mechanism of metformin. Usually, if you see metformin in any MCQ, the answer, if there is an AMP kinase written there, it might be the answer. Similarly here. So again, in the same journal as I mentioned before, activation of AMP-activated protein kinase or enhanced uptake of calcium by mitochondria in hepatocytes by metformin, it reduces the glucose output from liver, hence leading to the answer of this question. Which preoperative serum calcitonin level is considered the cutoff for defining low-risk MTC? It is less than 250, as also discussed in the talk just by Dr. Sasi sir. So they mentioned that patients with primary tumor less than 2 centimeter CN0 and preoperative serum calcitonin less than 250 are at a low risk of MTC. These patients could have been, like, we can try lobectomy in this patients, is what the article says. In patients with a sustained excellent response after total thyroidectomy for low risk DTC, we can discontinue the USG after 5 to 8 years post therapy. This is again from the ATA guidelines for 2025, as already discussed by Sir as well. So, for patients with low risk DTC with total thyroidectomy alone and a sustained excellent response 5 to 8 years after initial therapy, routine ultrasound can be discontinued. So ectopic thyroid glands such as lingual thyroid, how does it lead to reduced function? They lack the lateral lobes and have restricted proliferative capacity in response to TSH, and hence they fail to maintain euthyroidism. Again, mentioned in the Indian Thyroid Society flagship journal. So they have mentioned that immaturity of thyroid tissue along with low functionality associated with dysgenesis of the thyroid gland could be one of the reasons why hypothyroidism is much more common than hyperthyroidism in ectopic thyroid. Another reason could be that an ectopic thyroid is usually much smaller in size and may not have adequate tissue to produce enough thyroid hormone. A simple logical answer. What is the most common type of thyroid carcinoma arising within the thyroglossal duct? Many of us would have guessed it correct. It is papillary thyroid CA, which is the most common answer in most of the questions like these. Probability of carcinoma arising in such tissue is less than 1%, but the reported histopathology of these tumors, 80% of them had PTC, while follicular variant 8%, squamous 6%, and the remaining 6% had follicular Hertzley anaplastic cancer. For a patient with a unilateral, that is single-sided, low-risk DTC, the preferred initial surgical approach, as mentioned in the previous lecture as well, is thyroid lobectomy. They have mentioned that if the dissection is performed for patients with thyroid cancer less than 2 centimeter, without gross extrathyroidal extension, and without metastasis, the initial surgical procedure should be a thyroid lobectomy, unless there are bilateral cancers or other indications to remove the contralateral lobe. Second last question. According to the 5th edition of WHO, morphological features required to classify as DHGTC, that is differentiated high-grade thyroid carcinoma. Answer is mitotic count of more than 5 per 2 millimeters square or the presence of tumor necrosis, as also mentioned by Dr. Sasi sir in his talk, as mentioned in the 2025 ATA guidelines. In the management of thyroid eye disease, how does the the CAS score guide treatment differently than the SS? We know the answer. The high CS requires immunosuppression, while high SS without active inflammation may require surgery. A very easy question. Again mentioned in the ITS journal. They have mentioned that active and progressive disease may benefit from immunosuppression, but patients with inactive burnt out disease are only amenable to surgical intervention. I think that was the discussion as well.
Tech team, we have the results of the DM quiz.
Yes, sir, we have. Just sharing this.
Sure.
After this, I'll quickly discuss about the practitioner's quiz answers as well, which was a very interesting quiz with interesting questions.
Okay, so this is the winners of the DM quiz, and the first prize goes to Dr. Shravani, and second is Dr. Isha, and third is Dr. Skar. congratulate all the winners, and you will receive a certificate of appreciation and merit from the Indian Thyroid Society by email. Congratulations to all the winners. Dr. Suyash, you can discuss the answers to the practitioner's quiz, and then we'll declare the results of the practitioner's quiz.
Sure, sir. Thank you. So practitioner's quiz had more of easier questions, as I would say. So first question was Dr. Thomas Wharton, who named the thyroid gland, chose the name based on the shape of which structure. Many of us think that it is the butterfly-like symmetry of the neck or the thyroid gland two lateral lobes, but actually, surprisingly, it was the nearby thyroid cartilage based on which he gave the name. How does biotin supplementation affect thyroid function test results? Many of the multivitamins have biotin these days and can lead to falsely reports of low TSH, high T3, and high T4. This was again mentioned in the flagship journal of Indian Thyroid Society, where they have mentioned about hair and nails when we give biotin supplementation. It can lead to this result. The recommended starting dose of levothyroxine for a newly diagnosed patient with subclinical hypothyroidism in pregnancy. Many of us have marked it incorrect. It is actually 1.2, as mentioned again in the ITS journal, that the starting dose of 1.2 microgram per kg per day can be considered in such patients. Following, which of the following describes the effect of hypothyroidism on the accuracy of HbA1c measurements? False elevation due to reduced blood cell turnover. This was mentioned in the Indian consensus statement on hypothyroidism and diabetes. Again, this was a part of the ITS publications as well. They have mentioned about this particular answer. The recommended screening protocol for thyroid function in patients with type 1 diabetes. We get many type 1 diabetes patients, and they are increasing at a very fast rate in our OPDs. The answer is screen for TSH and free T4 at diagnosis and then annually. We forget the annually part, which is very important. This is again mentioned in the Indian consensus statement published by the Indian Thyroid Society. The recommended optimal duration for ATD therapy in Graves' disease is 12 to 18 months, again mentioned in the journal, the article by the journal. This publication focuses on the management of hyperthyroidism and is a very good article to quickly get a hold of the management protocols. Primary therapeutic goals when using RAI therapy for Graves' disease is not induction of euthyroidism, as many of us have marked. It is induction of hypothyroidism. This is again given in ITS journal. The overarching therapeutic goal of Graves' disease is the induction of hypothyroidism in affected patients. Which of the following is not a physical examination finding that suggests an increased risk of malignant potential in a thyroid nodule? We must ask these questions to all our patients. Firmness, fixity, and cervical adenopathy, among others, are an indication that there is increased risk of malignancy, but not tenderness. So this is very important to ask to every one of our patients with thyroid nodules: history of head and neck irradiation, family history of such cancers, age less than 14 or more than 70, male sex, growing nodule, firm or hard consistency, cervical adenopathy, fixed nodule or persistent dysphonia, dysphagia, or dyspnea. If we have any of these factors, we should think about high risk of malignancy. 35-year-old patient diagnosed with apparently sporadic MTC. What is the recommended next step? Germinal red mutation analysis for all those patients is recommended, as told by many different articles, including the articles published in the endocrine reviews, as well as the JCEM. So they say that germline red sequencing for all patients with MTC, regardless of family history, should be done, because up to 50% of MEN2 cases may present without known family history due to de novo mutations or incomplete penetrance. Which of the following is an absolute indication for total thyroidectomy in DTC? It is clinically positive cervical lymph nodes, as mentioned in the ITS journal article. For patients with thyroid cancer more than 4 centimeter or with gross extrathyroidal extension or clinically apparent metastatic disease to nodes or distant sites, a near total or total thyroidectomy and gross removal of all primary tumors should be recommended. I think that finishes it. Thank you.
Thank you, Dr. Suyash. Can we have the winners of the quiz?
Sure, sir.
I think. Okay, the winners of the practitioners quiz. I congratulate the winners, Dr. Mohammad Ghaus, Dr. Sudha M, second prize, and Dr. Pooja Baradia, third prize. You will receive a certificate of appreciation from the Indian Thyroid Society by email. Thank you, Dr. Suyash, for the excellent quiz. I think we had a lot of learning points. Over to Dr. Ganavi.
Thank you, sir. So thank you, Dr. Suyash, and for conducting a very interesting quiz. So, and discussing the answers as well in extension. So, as we conclude today's session, sir. As we conclude today's session, I'd like to invite Dr. Pramila Madam to share the closing remarks. Over to Madam.
Yeah, thanks, Dr. Ganvi. I think we had a very interesting discussion, starting with the discussion on medullary thyroid cancer. Dr. Sherin nicely presented it and moderated by Dr. Asha and Dr. Chanukya, and we had a lot of learnings from that as well. And Dr. Sasimoli talked about the ATA 2025, what's new and what's different from ATA 2015. And I think, as he rightly said, that we need more time for these guidelines. Maybe we'll keep one more session to discuss these guidelines. And the quiz was definitely very good. And I think the students definitely have a great learning, and all of us learn from the quiz every time. So, and it's nice to see our students do so well. Dr. Suesh, who is our previous student, he is now in Bhopal, but he's doing so well. So it's so nice to see your students doing good in their lives and in their career as well. So with this, we today end the today's session. But before that, I request all of you to please send your articles to our journal, that is the Thyroid Research and Practice. This is the official journal of the Indian Thyroid Society. And very soon we are getting the DOAJ for the journal. And also, please become reviewers of this journal, because we want more and more reviewers also. So all the faculty who are participating and any of the faculty who have joined online, I request all of them to please become a reviewer for Thyroid Research and Practice. This is our ITS journal. And please help us to review the articles as well. It will be of great help. So with that, I hand it back to Dr. Ganvi to carry forward the proceedings for the next session, and she will tell the dates of the next ITS clinics, and we hope to meet soon again.
So our next, thank you, ma'am. Thank you for the closing remarks. Our next thyroid clinic session is scheduled for the 8th of July. So we request everyone who's joined in today to join for our next session as well. Thank you all for joining, and good night, everyone. Thank you, ma'am. Thank you, sir.
Thank you.
Thank you, ma'am. Thank you.
Thank you. Thanks, everyone. Good night. I think we had very nice